Um, for now, until the presentation starts. So good morning, good evening, and good night from everyone across the globe that's joining us for this edition of the EIOC Journal Club. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, the very warm, and the very safe United Arab Emirates. I'm joined today to discuss actually a very, very important topic, which is really looking and deep diving into methodologies by which we can improve prognostic outcome of our patients with early stage breast cancer, hormone receptor positive, HER2 negative setting. And I'm joined today by amazing international and local faculty. Our international faculty is none other than Michael Gnant from Austria. Michael, maybe you can introduce yourself.
Yes, thank you very much, Shaheenah. Glad to be here. Sad not to be able to come to Kuwait this time. I've been there a couple of times and always enjoyed the discussion and interaction with our colleagues. I'm a professor of surgery at the Medical University of Vienna, and I'm leading the Austrian breast and colorectal cancer study group. And I'm honored to be invited to give you some impulse for the discussion tonight.
Thank you. Anwar.
So my name is Dr. Anwar Al-Nouri. I'm a medical oncologist at the Kuwait Cancer Center with my colleagues, Dr. Rehab and Dr. Mae and Dr. Faisal. And I think, yes, Dr. Gnant, we had you in Kuwait during actually the Euros last year, the year before. So, yeah.
We will get Michael back once the situation is calmed down in the GCC region. Faisal, please introduce yourself.
Faisal Terkait, Kuwait Cancer Control Center, medical oncologist practicing breast cancer and swimming.
Mae.
Hi, good evening from Kuwait. So yeah, I'm one of the medical oncologists on the breast unit in Kuwait. And Shaheenah, actually, I have heard a lot about you from Prof. Johnston. I did my fellowship at the Mars, and he spoke very highly of you. So it's good to finally meet you virtually, hopefully in person soon.
Thank you. Hopefully in person soon. Rehab.
Good evening. I'm Dr. Rehab. I'm also from KCC Kuwait. In breast unit working with Dr. Anwar, Dr. Mae, and Dr. Faisal.
Thank you. So without further ado, if we can show the agenda, please. The program is actually split into two parts. The first part is actually a presentation from Michael, followed by a panel discussion. So Michael, maybe you can take it away.
Yeah, thank you very much. Let me share my slides. I have been tasked with addressing a little bit methodology, and as a clinical trialist, I'm happy to do so. However, I will, don't worry, it's not going to be a mathematical talk, but a clinical perspective and integrating the newest disclosures of major clinical trials in the adjuvant treatment of luminal breast cancer. So here are my disclosures. This is where I live. Actually, it's not exactly my house. But it's Vienna, city of
Wouldn't
music.
you love to live in that house, Michael?
I'm not so sure. I think the heating cost is pretty substantial. So during winter, at least, we have the opposite problem that you have in the Gulf region. Austria is a tiny country in the heart of Europe, but we have great breast cancer patients, 30,000 of which contributed to prospective randomized trials in the last decades. And this makes us a little bit bigger on the map than we are on the map. And it's also a reason why the famous St. Gallen Breast Cancer Conference has moved to Vienna about 10 years ago. And I would hope to see many of you in, almost 10 months' time in Vienna, and hopefully travel is less restricted by then. This is also called the largest tumor board in the world because after 3 days of high-level state-of-the-art presentation, there is the consensus meeting, and 80 faculty from all 5 continents basically try to define the standard of care, try to define knowledge into clinical benefit for our patients. And probably most of you have at some point downloaded the most recent manuscript about these recommendations from Annals of Oncology. So luminal breast cancer, obviously everywhere in the world, is the most prevalent subtype of breast cancer. And it has a certain characteristic that I think we need to keep in mind when we discuss the trial results, other than triple negative or HER2 overexpressing breast cancer, where one can almost say, okay, after 5 years, there's no more relapses, as you see in the light gray shaded curve here. I kept saying 5 years. Now I saw a patient after TNBC after 5.5 years recurring, but it's fair to say that the vast majority of recurrences occur in the first 5 years in those subtypes. Quite differently in luminal breast cancer. As a matter of fact, when you observe long enough, more than 50% of all relapses occur late, after 5 years. And the risk of recurrence, while being smaller in the beginning, obviously persists. And as a matter of fact, we did some calculations in my country. Around year 11, the luminal breast cancer patients catch up, so to say, with their triple negative fellow patients or HER2 overexpressing, and from then on actually have a worse prognosis in general. One of the unresolved mysteries, and maybe we can shed some light on this in our discussion, but I'm still not knowledgeable and able to explain that. Even after 15 or after 20 years, the risk of recurrence depends on the baseline risk factors. And most of us would believe that the source of late recurrence is dormant tumor stem cells, which hide in the bone marrow niche for stem cells or something. And then by an imbalance of promoting and suppressing factors might lead to overt clinical disease or metastasis. But it's not very clear, and research is very difficult and challenging for tumor stem cells. How do these cells remember after 2 decades that they originate from a larger tumor or from node-positive disease or from a more aggressive, biologically more aggressive disease? And as a matter of fact, the statistics show us that they do. The annual risk of relapse, even in year 21, depends on the baseline risk factors. Now, when we discuss all these new publications and disclosures and clinical trials, we need to remind ourselves about the level of evidence. I'm not saying real-world data is, and I'm going to show actually some real-world data because they can augment our knowledge, but obviously the randomized controlled trial, and I'm going to allude to this on some examples, is the highest standard in defining practice, particularly when more than one of such trials defines a new standard of care. And then that means that usually it goes, a certain treatment or a certain new drug goes to the clinical practice guidelines, whether that would be NCCN or ESMO or AGO or some of the others we are all using. So risk assessment matters for actual clinical decision-making. And yes, we have positive axillary nodes, still an important risk factor. We do have large tumor size, which you probably see more often in your practice than I do. But there is also a clear evidence that indicators of biological aggressiveness, and you can use tumor grade, you can use a more expensive multigenomic assay, you can use Ki-67, they all eventually measure the biological aggressiveness or proliferative capacity of the disease. And when you look at the risk of recurrence, as I've said, you see that in the nodal status, this even until 20 years is an important risk factor. However, it's not the only important risk factor. because we see that node-negative patients, if they have what we call high-risk node-negative patients, look at almost a similar risk of recurrence as node-positive patients. So in the graph here that I think was presented first from the Flatiron database by Kamal Shaveri, you can see that the N1 patients and the high-risk dotted blue line in the middle, they have almost overlapping overall recurrence risk. And that's something to keep in mind. So node negativity does not necessarily mean that this is not high risk. And when you actually look at the SEER database and the mortality risk at 5 years, you see that stage 2, 3, and node positive plus high risk has a similar risk than TNBC. And only the non-high risk patients, despite maybe they may be node positive, look at a markedly reduced risk. We have some real world evidence, in this case shown in San Antonio 1.5 years ago by Sarah Tolaney from the Dana-Farber Cancer Center. And again, you can see that within the node positive group, more specifically within the N1 patient group, you see that high risk features, additional high risk features, convey a more than doubled increased risk of recurrence. I know that there is a controversial discussion about grade because there is inter-observer variability here. I have the luxury of having excellent pathologists who do a lot of standardization work, and their grading assessment is pretty good. That may not be the case everywhere in the world, but high grade, even after 20 years, remains an independent risk factor because it's an indicator of proliferation. Maybe in the future we can use additional prognosticators. Circulating tumor DNA is talked about a lot. We have all kinds of issues, tumor-informed versus generic assay, how to use them. You saw probably the recent non-approval of the SERENA-6 data by the FDA, because actually some people might say, as long as there is no overall benefit measured in overall survival in terms of SERENA-6, there is no benefit in starting treatment early. Obviously, some of our colleagues might see this differently. And just a single measurement, this is I-SPY data, just a single measurement of baseline ctDNA in a very quantitative manner differentiates between patients at very low risk, somewhat limited risk, and high risk. So probably after we resolve some of the more methodological, probably also economic questions around measuring circulating tumor DNA, this will be part of our diagnostic and risk assessment armamentarium. Now, I have been asked to remind ourselves a little bit of interpreting trial results. And I think it is important to do so because usually when some of these large trials are reporting their primary or updated results, then we are all swamped by our colleagues from industry with different interpretations and all of that. And I think we need to remind ourselves what is the actual benefit behind all these figures. Absolute benefit, relative benefit, eventually defined by the hazard ratio, because the hazard ratio defines correctly the true difference between, let's say, a control arm and a treatment arm in a clinical trial. And it gives us a multiple of the improvement in a specific endpoint, whether that be IDFS or overall survival. Now, you can also do time-dependent medians or cutoffs and look at point estimates and all of that. The general experience after now a few decades of adjuvant breast cancer research is that usually the relative benefit is rather similar across the risk continuum, which obviously translates into different absolute benefits based on the baseline risk. And I'm here making something up. This is a theoretical treatment. We don't have such a treatment in luminal breast cancer, a hazard ratio of 0.5. That means cutting the risk in half. Now, when you apply this hazard ratio to a baseline risk control arm of 50% at 3 years, 5 years, 10 years, then your treatment arm will go up to 75%. So the absolute difference here is 25%, the delta. The very same hazard ratio, very same benefit applied to a low-risk population, baseline risk 90%, cutting the risk in half means that your treatment arm goes to 95%. And this is just 5%. And I remember very well, we had a national ad board after the initial presentation of Natalie, Dennis Lehman, and some of my Austrian colleagues were voicing their disappointment. They say, well, it's only 2.8%. And I was challenging this, and I would say, well, what do you mean by only 2.8%? What is the absolute difference of anastrozole versus tamoxifen? Well, yes, it's 1.9% in the ATAC 100 data. What's the absolute difference of chemotherapy in a lower risk, adjuvant chemotherapy in a lower risk luminal breast cancer? It's maybe 3%, maybe 2%. So because we have become so successful in improving the overall prognosis of our patients with luminal breast cancer, we are crawling up these curves. And the individual steps we are making will inevitably lead to relatively modest, small differences. So let's review this a little bit in view of the CDK4/6 inhibitor data that have now matured. I don't have to explain to you how these agents work. They are essentially cell cycle inhibitors and target cyclin D1 and cyclin D2 and have revolutionized the treatment of metastatic breast cancer, are now more or less standard of care for almost every patient with luminal breast cancer and metastatic disease. We have 3 of them: palbociclib, ribociclib, abemaciclib. It's not the only one. On a global scale, you have to also mention 2 Chinese inhibitors, and there's a large number of CDK inhibitors in development and in clinical trials. But even by the structural comparison, you can see that they are different. They are not all the same. Abema is a little bit less specific. It also targets CDK2, some CDK9, which is good and bad. It's good because it has some single agent activity in early studies. It's bad because that's the reason for the diarrhea. Palbociclib and ribociclib look relatively similar. However, they have differential activity on cyclin D1 and cyclin D2. And as you know, this has also, to the surprise of some, led to quite different clinical trial results. Now, in general, however, CDK4/6 inhibitors have changed the outcome of metastatic luminal breast cancer, and they are part of all the guidelines. Now, when we go to the adjuvant setting, we need to, based on what I have said about baseline risk, we need to analyze what is the baseline risk in these 4 major trials done with Western CDK4/6 inhibitors. And as you can see, the light blue, the Penelope B, the German trial, post-neoadjuvant trial, these patients had the worst prognosis, followed by Monarchie, followed by Natalie, and the Pallas trial recruited the, relatively speaking, lowest risk patients in there. And this makes a difference because based on my theoretical example a couple of minutes ago, obviously the absolute differences in these trials will differ, even if they have exactly the same hazard ratio. So these were the initial readouts, and you know that palbociclib didn't do well. Both early breast cancer palbo trials were eventually negative. Pallas was even stopped. And we saw very promising early results from Monarchie and from Natalie. To be honest, when I saw Steve Johnson's first presentation, I think it was at ESMO in Madrid, if I remember correctly, in the year 2020, about the early Monarchie results, I was not personally perfectly convinced. because I saw very similar effects in Penelope B, early difference in these trials, and I was asking for additional follow-up, because as you can see here on the right side in the Penelope B, there was some early promising signal for % difference, but that benefit went away with further follow-up. In the lower risk patient trial, PALAS, 6,000 patients almost around the world in 21 countries, we never saw any benefit. So palbociclib is not used in the early breast cancer setting. Quite differently, this is now the latest disclosures of the 3 positive CDK4/6 inhibitor trials. You see Monarch E, the most mature, the oldest trial. You see Natalie, and you see the Donna A trial, Chinese trial that was presented at ASCO last year. It's the youngest trial, not very mature, but with rather comparable early Kaplan-Meier curves in there. Let's briefly talk about Monarch E. I mean, you know all this data. It's Abema for 2 years, added to the backbone endocrine treatment. And that's the most latest result presented in Berlin at ESMO last year. And you see that the hazard ratio is 0.73. But what is more interesting to me is that that early benefit actually persisted. And I believe as someone who treats a lot of early breast cancer, this is very reassuring. We can make a difference with early intervention, and our patients will benefit in the long term. And as you also know, Monarch E even showed an overall survival benefit. I mean, when you look at the absolute difference here, and remember what I have talked about a few minutes ago, this is less than 2% for overall survival. It was statistically significant. But that's the absolute overall survival benefit. And to me, it was actually surprising that any of these trials would ever show an overall survival benefit, because as you know, we have 3, 4, 5, 6 lines of effective treatment after recurrence, and usually an overall survival difference goes away, or at least is not statistically significant. When we analyze the Natalie study design, you will see essentially 4 differences to Monarch E. Number 1, probably most importantly, it also involves stage 2. So that's the broadening of the indication, going into the node negative space. Almost all stage 2 patients have been included in Natalie. So that's difference number 1. Difference number 2, 3 years of treatment instead of 2 years. I discussed it a lot with Dennis Lehman, who was one of the fathers of CDK4/6 inhibitors and also this trial. And he insists that because of the quiescence and senescence of dormant tumor cells, we should treat as long as possible. And he would love to have 5 years of CDK4/6, which was not possible for regulatory and other reasons. The third important observation in this trial is that the backbone endocrine treatment was more homogeneous. This is in Natalie based on aromatase inhibitors. Whereas in Monarch E, there is tamoxifen, and I'm going to discuss it because some of the benefit appears to be even driven by the tamoxifen. Fourth observation, as you also know, ribociclib was reduced in terms of the daily dose from the 600 that was successfully used in the Mona Lisa trials, 3 trials with an overall survival benefit. It was reduced to 400 milligrams per day for the adjuvant setting, which was a good move because it eliminated essentially the concerns of cardiac toxicity, QTc prolongations. So when you look at the inclusion of the populations, you can very easily see that Natalie expands the population to, as a matter of fact, in my country, almost twice as many patients as were included in Monarch E. So the latest disclosure, again, was given by John Crown in Berlin at ESMO, and you see this evolution of the data. And this is important to look on that because, yes, we always see very early results. And even before we see the results, we usually have the stock market exchange company disclosure, primary endpoint was met, promising results, and then we are left answering our patient's question without seeing any details. It is, however, important that we follow up on this And we have asked Novartis repeatedly to keep following these patients, and now there is the 5-year data. And you see that there is a very consistent reduction in the risk for invasive disease survival in there. Also now, this is the most latest 5-year data. Again, very similarly to monarchy, you see after the treatment stops, now everybody is off therapy in NATALEE since years, the benefit persists. The difference between the curves even appears to widen, and I'm looking forward to further updates, 6, 7 years, maybe 10-year results to see confirmation of that. Also, for clinical decision-making, we want to look into subgroups because we all see individual patients and not groups of patients. And that means that this is interesting. However, in these large adjuvant trials with thousands of patients recruited, usually in the forest plot, there is not really, at least not, let's say, a durable or reliable difference between subgroups, because the tests for heterogeneity, even if these curves in the forest plot go left or right a little bit, is usually not fulfilled. So essentially the message here is the addition of ribociclib works in all subgroups. There is no specific subgroup that benefits the most, and there is none that doesn't benefit at all. Distant recurrences are important because they are considered to be a surrogate parameter for overall survival, even if the trial, fortunately, because we are so good in treating metastatic breast cancer, has not yet reached the overall survival analysis. And you can see a clear trend that even when you look at distant metastases, the addition of ribociclib will improve the results. Now, this is an important slide because that's the breakdown of the NATALEE primary endpoint results by nodal status. And yes, we know that CDK4/6 inhibitors work in the node-positive setting. However, when you look at the node-negative setting, you see very, very similar results. Technically, numerically, even slightly better, which is a little bit of surprise, given my considerations that I have shared with you about baseline risk. What I also see here is that our colleagues who recruited patients to the NATALEE trial made very wise judgments together with their patients, because look at the 5-year result of the node-negative control group. 84.6% is not as good as my overall average node-negative patients. So they were very wisely choosing patients with node-negative, but additional high-risk factors. And the reward for this is almost 6% absolute benefit in that group, which I believe is really a game changer for patients who have aggressive disease despite being node-negative. So the overall survival difference now is 1.6% here at 5 years. You remember it was 1.8 at 7 years. We are waiting for further updates and more events and further follow-up of the trial. Currently, the hazard ratio is very comparable. The statistical significance is not necessarily there yet, but if everything develops as we would hope for, we are going to probably see that. That was John Crown's conclusion at ESMO, no new safety signals, and a persistent benefit over all analysis of the NATALEE trial. Speaking of safety a little bit, because that's always important for our adjuvant treatment decision, you know, the main safety issue with monarchy is the diarrhea, as with abemaciclib. We usually say, yes, it is well manageable, but that depends, obviously, a little bit also on the situation in life of your patient. If she's a primary school teacher or a cab driver, even grade 2 diarrhea might not be feasible in such a patient's life. The relatively good thing is that it usually occurs early, and once you manage to titrate your anti-diarrhea drug, then you can successfully treat your patients. An interesting observation that I have also discussed a lot with Stephen Johnson is, why on earth are you giving high-risk patients tamoxifen? Because that's something that was not really the standard of care since at least PIC 198 and ATAC and the IES trial 20 years ago. Yes, it's a global trial. There are some regions, such as Japan, where tamoxifen is still very popular. I mean, you look at the hazard ratio, you almost have the feeling that these 1,500 patients on tamoxifen have a better hazard ratio compared to the AI patients in monarchy. So that's something that I think needs to be discussed and considered. And it's also important to keep in mind when we discuss with the patient, like changing the backbone treatment due to side effects, which data do we have and which we don't have. Discontinuation rate overall around 31%. That's not all due to adverse events. It's also because of recurrence. But yes, keeping our patients on the treatment is an important challenge because a drug that the patient doesn't take cannot help. And sometimes it's really very difficult. The good news is that when you dose reduce, and you can do that with Abema as well as with Ribo, it appears from this analysis that you're not really taking any benefit away from the patient. It's much more important to keep the patient on the drug, even if you have to reduce the dose, than stopping the treatment. Ribociclib, I already alluded to, the reduction from 600 to 400 more or less eliminated the QTc concerns, which I think is really a good observation. 0.2% is nothing that we have to be too worried about. And eventually, when you look at the formal side effect assessment, it was actually the liver enzyme elevation that is the reason, the most frequent reason for treatment discontinuation in the NATALEE trial. And that's something to watch out for. It doesn't hurt, but it needs to be known by everybody who treats his or her patient with ribociclib. Again, you also can and should dose reduce in case some concerning side effects are occurred. You know all the guidelines, how to do that, when to stop, when to dose reduce. And again, the good news is when you have to dose reduce, you're not taking anything away. So in all these trials, there is a certain number of patients who from the highest dose went to no drug. And that's, I think, it was the pioneer time. We also saw it in the PALLAS trial. That's not what we should do. We should really fight for our patients to stay on treatment if possible, because that preserves the benefit they have. So when you look again at the summary here, eventually very similar rates, little less than 20% of patients eventually stop within these 3 years for adverse events. That's very comparable to monarchy. And fewer patients in NATALEE had those reductions because of adverse events, because it's 43% in monarchy, going back it's 23% on Ribo, and the discontinuation rate is very similar. As everybody knows, diarrhea, fatigue can be an issue with Abema. So these are the most updated results. In closing, just briefly, and maybe for our discussion, talking a little bit about the future, we see new classes of drugs arriving in the treatment of luminal breast cancer. Obviously, the oral SERDs, huge investment by several manufacturers, more than 20,000 patients on this slide. The early results of the lidERA trial we have seen in San Antonio, and I think we will have to discuss on, yes, if it becomes available in the future, should we use an oral SERD? Now, number one, we need to wait for the other trials, the Cambria trials, the EMBER trial, the ELEGANT trial. And these other trials, other than lidERA, they have a significant proportion of patients who also got a CDK4/6 inhibitor. And sometimes we have these discussions, well, if I can use a SERD, I may not need to add the ribociclib. I'm not so sure about that. My personal bias would be that the CDK4/6 inhibitors have a different mechanism of action. Again, as I said, the stop sign to the cell cycle. So by nature, they will be anti-proliferative. They will act particularly on early relapse. An additional backbone that is targeting the estrogen-depending pathways, including also in stem cells, might have a completely different mechanism of action. And personally, I would expect that when we see these trials reporting, I would not be surprised that if there is really a true addition of a SERT benefit and a CDK4/6 inhibitor benefit. It's going to be complex because SERTs are not the only class of drugs that are moving into the luminal breast cancer treatment. We have PROTACs, we have SERANs, we have SERCAs. We saw the initial Tegestrant results at ASCO and now with the FDA. So we are going to have quite a number of interventions in our therapeutic armamentarium. And the diagnosis, and I already alluded to SERENA-6, I'm not going to dwell on this, but moving the liquid biopsy technology from characterizing metastatic disease to the early breast cancer setting, using it as a tumor marker, as an indicator potentially for early intervention, is something that many of us around the world discuss or try to study in clinical trials. And then this just picked some excellent Chinese work from Fudan University in Shanghai. There is additional subtypes of luminal breast cancer. Well, not everybody can do multi-omic subtyping as they do in Fudan in clinical practice, but they were able to identify patient subgroups who would particularly benefit from a CDK4/6 inhibitor, but also, for example, for immunotherapy that we are not generally using in the treatment of hormone receptor-positive breast cancer. Eventually, I think the outcome benefits are the most important denominator of our decision-making together with the patient. But obviously, the quality of life issues, including the patient's situation in life, age, family planning, all these things also matter. And that's what we also do. So this is my take-home message. Eventually, we have really greatly improved outcomes in luminal breast cancer. However, there are patients that look at high risk of recurrence, even when they are not negative sometimes. And both of these trials have transformed the advances from the metastatic setting to the curative setting, which I think is great news. Personally, I increasingly focus on drug adherence and on tools in improving that, because a drug that is not taken simply cannot help. And it's important that in our shared decision-making with our patients, as we all do every day, we keep these things in mind. It needs time, it needs empathy, it needs communicational skills. But I'm sure that that's exactly what will help us in moving ahead by working together. This is a self-painting of one of my patients, one of my favorite paintings. Eventually, this is why we do all of this research, continuing education, our discussions. It's for the patients who are trusting us. Thank you very much for the invitation again, and I hope to see many of you in Vienna in March 27 for the next edition of the St. Gallen Breast Cancer Conference. Thank you very much.
Thank you, Michael. That was an amazing overview, giving us insight on all the different aspects of CDK4/6 inhibiting, and of course, the futuristic aspect. I have a number of questions. I don't know if anybody else has some questions before we go into the case studies, but I'm just going to be an opportunist and ask my questions. You have presented the results of the ctDNA analysis of a number of trials, so looking at its use in the early stage setting. But I have certain concerns about ctDNA use in this particular subgroup of patients. I see a lot of clinical utility and benefit in the triple negative cohort, but what I've repeatedly seen in the early stage setting for hormone receptor positive, and really I'm drawing a lot of my conclusions from what I saw in Monarch E, is that even when you have a very high risk group of patients, only a very small cohort actually have ctDNA positive disease. And of course, they always do worse than the ctDNA negative. But that's not to say that the other high-risk group are not going to be having a worse prognosis. So what are your thoughts there? Is it as good in this subgroup of patients, or do we need more data before we start utilizing it? I just had a patient come to my clinic with high-risk disease, and she's telling me to do Signatera for her, and I'm like, but there's no clinical benefit for me to do Signatera for you right now.
No, I couldn't agree more. I mean, I was looking into the future. I'm not using it. I have similar experience. We have quite a number of analytical questions, health economy questions, and the benefit is not clear because number one, is it accurate? And yes, even if it is, can we do something about it?
Exactly.
And I keep telling the story. A few weeks ago, a patient of mine, an educated patient, and she read about it, and then she asked me, "Can we do a test?" And I said, "Well, yeah, you can pay for it because it's not reimbursed in my country. But and then what are we going to do if you find some traces of the enemy?" And I said, "Nothing." And she thought about it, and then she said, "Then I don't want to know." And I think that's a very wise conclusion at this stage of the progress. We will have to formally investigate. That's challenging for me as a trialist, because theoretically you would have to randomize ctDNA guided versus blind treatment. And it's not so clear what is the endpoint. Is it an early MBC trial where you should use progression-free survival as an endpoint? Is it a late adjuvant trial? Then you should probably use IDFS. These questions need to be resolved before we can act on it. However, we all have patients who arrive with some tests they did somewhere and paid for it, and sometimes they are controversial. So I think we should give the message that you are suggesting to our patients. This is not ready for prime time. We are actively working on it, but don't base treatment decisions on liquid biopsy in early breast cancer at the moment.
And the second question I wanted to ask you, I mean, you so nicely pointed out when you're interpreting data, it's not only about looking at absolute percentage benefit, but really looking at that proportional hazard ratio and looking at that, risk reduction that you're getting there. Now, I'll give you a very practical example. I had a patient that had gone through her chemo, her surgery, her radiation therapy. I put her on endocrine therapy, and I'd always told her that she would need to get on a CDK4/6, but she was so fed up at the end. I went through it, and she asked me, what is the benefit? And I told her the absolute benefit is 5%, figure that I've put out there. But the relative benefit is much, much higher based on the hazard ratio. And she could not comprehend that. She could only think 5%, it's not enough for me. So how do you communicate that information to a patient to make them understand? Because as physicians, we understand, but it's very difficult sometimes to put it out there to a patient.
Yeah, I hate to correct you, but not all physicians understand, to start with. I live in the privileged setting that I usually see rather educated patients, and I actually draw a couple of Maya curves for them. And I do something like the example I shared with you, the theoretical example, in making clear, and this is usually disappointing, because as patients, and it's the same for us if we were to be patients, which could happen any second in our life, like a single-digit benefit is not what we expect. We want to have 50% and cure. So I think we need to communicate this very carefully, but make clear that a 4 or 5% absolute benefit is absolutely worthwhile. And even by the very difficult standard of the ESMO clinical benefit scale, which I believe is actually too tight, is a treatment that should be considered a standard of care.
All right. I have lots of other questions, but I know I have to go through these cases as well. So please bear with me. So the first case is of a patient. She's Asian. She's 50 years old. She's pre or perimenopausal. She's employed. She has an active lifestyle. She is diagnosed, unfortunately, with a hormone receptor positive, HER2 negative early stage breast cancer. It's a T2 disease with a 4-centimeter tumor, grade 3, node negative, oncotype DX, not available. KIC7 is 40%. Michael, if oncotype, because we've faced this as well, simply because of insurance approvals and things like that, would you do surgery up front here, or would you do chemotherapy up front, or would you just not do chemotherapy in a patient like this if you didn't have the oncotype or any other type of genomic profiling results?
Actually, I never have oncotype because we cannot order it. The issue with the neoadjuvant chemotherapy of luminal breast cancer obviously is that you don't want to give chemo to a patient who doesn't need chemo in the adjuvant setting, but you may not want to miss the chemo if there's an opportunity, for example, to shrink the tumor. So this is 4 centimeters, which might pose some surgical challenges. You know that I'm a radical breast conserving surgeon. And even if we don't achieve PCR, because that will only be 10 to 12% in luminal breast cancer, let's say even a minor response from 4 to 2.5 centimeter could be very helpful to achieve breast conservation. Second item here is what I would rely on. This is grade 3. It's a Ki-67 of 40%. I would consider it highly unlikely that the oncotype is low risk in such a patient. And based on these 2 considerations, she would be a candidate for neoadjuvant chemo in my center, yes.
So, Dr. Faisal, this patient did not get neoadjuvant chemotherapy, underwent surgery, but I completely agree with you, Michael. I think this patient should have received neoadjuvant chemotherapy, but this patient didn't. Faisal, what would you do in the adjuvant setting for this patient?
Yeah, so in addition to what Michael was saying, my concern in those patients when I see them and when the surgeon discuss with me is the fact that there's about 10 to 15% risk they'll do the surgery and we find they have node positive as well. So I would prefer, if I'm most likely she will have adjuvant chemotherapy, therefore if I'm going to give it in the adjuvant, I prefer to give it in the new adjuvant. This is luminal B. The baseline risk is very high, so I would go with the full house adjuvant chemotherapy followed by, you know, what we've discussed today.
And Mae, what would you do here? And which CDK4/6 inhibitor would you use? You're muted. You're muted.
There we go. Hi, yes. So I agree with everything that's been said. I think if neoadjuvant chemotherapy is on the table, I would prefer to go with that. But if they had gone with upfront surgery, yes, I would offer, and without an oncotype, I would still offer adjuvant chemotherapy, depending on the surgery, obviously adjuvant radiotherapy. But then, yes, I would treat them with the endocrine therapy in addition to a CDK4/6 inhibitor. And because she's a node negative patient, then ribociclib is the CDK4/6 inhibitor we'd be offering.
So, I mean, Michael, if this patient had an oncotype done and it was an oncotype of 20, say suppose, or maybe even less than that, let's make it 10. But the Ki-67, as I pointed out, was actually 40%. And we've seen this happen. I've seen it happen quite often in my clinic where someone comes to me with a Ki-67 of 40% and their oncotype turns out to be low. I know this cohort of patient was included in Natalie, but with a low oncotype, because they were trying to have those node negative patients that were really high risk, but now you have a low oncotype, but a high Ki-67 as per definition. What would you do here? Would you offer adjuvant ribociclib?
Probably I would. I would offer definitely. I would discuss very precisely with the patient that she might approach the lower limit of risk and therefore the relatively speaking lower absolute benefit as compared to someone with super high risk. I might consider this when we have to deal with side effects, maybe a reduced threshold for dose reduction or even discontinuation. But I'm in my practice, as I told you, fortunately, I enjoy high quality pathology. And if they tell me it's high grade and it's 40%, then I would, even if the oncotype is there, probably go with these indicators of increased risk.
Okay. All right. So when we looked at the recurrence risk for patients with node negative and node positive disease, and you look at those patients with node positive and node negative, those node negative high risk have a very similar recurrence risk compared to the node positive. Anwar, what are your thoughts over here?
We see this in the clinic, so the data shows that, and we discuss it all the time in the MDT. So some patients have what appears at the beginning when you look at the pathology that they seem to be low risk, but then when you actually look more details, you can find that they have high risk features. And those actually behave more closer, as you said, to the N1 rather than to the N0 low risk patients.
So, Michael, one of the questions that we've asked repeatedly is that Natalie allowed us to broaden the cohort of patients that would benefit from an adjuvant CDK4/6 inhibitor compared to Monarch, which was a very, very unique high-risk cohort of patients. Now, they expanded it till T2. But what if you have a patient that's a T1 and has all the high risk features, high oncotype, high Ki-67, grade 3 disease, lymphovascular invasion, all the other paraphernalia that goes around saying that this patient has a high risk. And we have data from the Early Breast Cancer Trials Collaborative Group that tells us these patients also have high risk. Would you deny that patient a CDK4/6 inhibitor if you were allowed to give it in your country?
No, I'm not sure I'm breaking any regulatory rules here, but I will tell you, I fortunately live in an environment where we can, with justification, extend the formal label, and that would be exactly a patient where I would at least discuss it. Again, that combination of adverse risk factors is never counterbalanced by a smallish tumor size. Actually, in our trash talk in our MTD, we call this a small devil. And I will go with the presumed recurrence risk and try to get reimbursement for this patient, which in my personal environment, fortunately, at least for now, is usually possible.
All right, so in the interest of time, I'm just going to go. So I wanted to look at this slide that you also presented, which looked at the node negative cohort as well as later on the node positive cohort. And you can see for the node negative cohort, it was very interesting to me that when the data was presented for the 5-year, the benefit, of course, continued to increase, which was tremendous. This is what we expected to happen. But in the slide that you presented, Michael, you actually put it side by side with the node positive cohort of patients. I felt the benefit was actually higher in the node negative than in the node positive. How do you explain that?
Well, I think probably between 4.8 and 5.6%, it's a little bit the play of chance. I mean, with the number of events, there could be a couple of events going the other way, changing those post-digit figures. However, I absolutely agree with you, and I think our colleagues who recruited patients worldwide to the Natalie trial have to be applauded. I mean, this 84% means they chose exactly the node negative patients that are the ideal candidates. I mean, my average node negative 5-year IDFS where I practice is probably around 93%. So they did a very good job in exactly selecting the patients like you were describing. And I think we can take it for a fact. It's now stable since several analyses, and it's very unlikely that that benefit in the subgroup will considerably change. It's more likely that it will actually be increased over time, as we have seen multiple times.
I can tell you the way I interpreted it was exactly the same as the way you interpreted it, but the thing that I thought the most was, and maybe you can chip in over here, I thought that in the node positive cohort of patients, Natalie allowed every node positive patient to be actually included, and you had that huge group of patients, N1, that were actually not that high risk to begin with, but in the node negative, these were really high risk. These were high risk based on the Ki-67, high risk based on their oncotype, on their genomic profiling. So I felt that that was what was driving the bigger benefit that I was seeing in the node negative. As I go into the next case, Mae, what do you think over here?
Have a look. So 55-year-old postmenopausal woman, 42, grade 2, node positive, 2B, Ki-67 is 35% with a high oncotype score. So what would be the treatment option for this patient? So this is somebody who has not had surgery yet. This is a question of whether or not, or have they been operated on? Is this a pathological stage?
It looks like this patient's been operated on. And this patient has a node positive disease, is a stage 2B. Ki-67 is 35%. Before you go into that, Mae, Anwar, would you have done an oncotype over here for this patient? Ki-67, 35%, grade 2, 4 centimeters. I know postmenopausal, but would you have done an oncotype?
I would have does she fit the criteria for our responder to have an oncotype? The answer is
Does
yes.
fit. She fits the criteria for
Yeah.
our responder, but does she really need an oncotype?
So that's then the second thing. So then if the patient has a really strong feeling that she is against taking chemotherapy, and I showed yesterday in the graph, the oncotype, the correlation between the grade and between the size of the tumor and between the clinical risk. So you can have high risk score with low grades. You can have high risk scores with small tumors, and the opposite can happen. But she does, I have to say that she does have high risk features. The size I'm not comfortable with, and the Ki-67 also. So if the patient was not so keen on doing it and she was keen on doing everything in terms treatment-wise, I would think it's really reasonable to go with chemotherapy in that case without an oncotype.
Okay, and Rehab, what are your thoughts over here? You're
Mute,
muted,
Rehab.
Rehab. You're muted, Rehab.
In KCC, we can do oncotype for the patients, but this patient, though she's postmenopausal, but she's young, and also the lymph node positivity, the Ki 35%. I guess this case will be discussed in our breast unit meeting, and I think most of us will go, will give chemotherapy, even if we don't do oncotype.
So, Michael, this patient would fit both the Monarch E criteria as well as the criteria for Natalie. Now, let me just change
she?
things around. Pardon?
Does she? Does she?
Yeah, she's got a Ki-67 of 35%, so it's like an additional risk factor. So she does actually meet the criteria. Michael,
I
what
thought
is
they
this patient? Yeah, go ahead,
removed
Faisal. Go ahead.
Ki-67. No, I thought Ki-67. I know the risk is high, and I know she might, but the FDA removed the Ki-67.
Yes, they removed yeah. So, Michael, let us assume this patient had, I'm going to change it for different scenarios simply because we don't have a lot of time and I want everyone to leave on time. So, Michael, let us assume this patient actually has 10 lymph nodes that are positive. You have the choice between ribo and abema, right? The proportion of patients in Natalie that had 10 lymph nodes that were positive much lower than that in Monarch E, but the outcome same. Which one would you choose?
Yeah, that's the crunch question. I keep being asked a lot, what are you doing in the overlapping population? With the two nodes and the Ki-67, this is actually, whether cohort 1 or 2 is approved in your environment. So that's a little bit of a difference. Honestly, I think in a few years, we will exchange these drugs like we do with anastrozole and letrozole. Currently, obviously, there is a huge also competition between companies. To me, efficacy is, as you have rightfully said, similar. Now, I would never put this patient on tamoxifen based on my risk assessment. I will ask for the side effect expectation. This is quite different. We don't know that. What is the situation in life? As I have said, if the patient has, she's a housewife, so you can say lower grade diarrhea might not affect her, but she could have cardiac morbidity, which obviously would not be a good, or taking some drugs that increase QTc or something. So it's more these aspects that eventually will guide my decision. So I cannot give a firm answer, and just because Novartis is graciously sponsoring this, I will not say this is a ribo patient. I think if we have two options, it's good for us, it's good for the patients, it's good for hopefully prices coming down because of the company competition. And then it is a discussion about the tolerability and situation, life situation. And then I sometimes keep being asked, well, the patient cannot tolerate the AI. She needs to go on tamoxifen, would not also switch to abema. I would not. I think fast forward 3-4 years, we will more generously or deliberately exchange these drugs for each other when the marketing war has subsided a little bit.
Okay, so very quickly, Anwar, the case that I just presented, 1 lymph node positive, grade 2, high Ki-67, what would you give? abema, or ribociclib. So it's not a very high risk with 10 lymph nodes, but one lymph node, oncotype 27, and grade 2 disease with a high Ki67. What would you give, ribo or abema? Very quickly, then I go to Faisal, Mae, and Rehab.
Ribo.
Ribo. Dr. Faisal.
Yes, rival.
Mae, you're muted. You're
You can
muted,
circle.
Mae.
I think I have to say ribo.
Okay, Rehab.
I will give ribo, but I will discuss also the side effects with the patient for both.
Oh, I
But I
like
will
that
prefer ribo.
diplomatic answer. I like that very much.
Excellent. And I hope that whoever you choose now will give you a travel grant to attend St. Gallen in Vienna in March 27.
Well, thank you all. This has been a spectacular edition of the EIOC Journal Club. You've all been tremendous. And Michael, thank you so much for walking us through that data. It was actually a very nice interpretation of how to understand the data. I think we've got two CDK4/6 inhibitors. Both are effective in the adjuvant setting, giving our patients options. Of course, you have to individualize therapy based on the tumor characteristics and, of course, the tolerance profile and toxicity profile of the patient that is sitting across the table from you in the clinic. I think interpretation of the statistics and how you convey that information to patients is also just as important. So thank you all for this edition of the EIOC Journal Club. I hope to see you at the next edition. And Michael, I'm sure you're at the ESMO Breast, so please enjoy it and then bring us back the information that I'm sure will be updated this year. Thank you.
Thank you.
Thank you.
Thank you.
Take
See you
care.
soon,
Bye.
hopefully.
Thank you
Bye,
very
bye,
much.
bye, bye, bye.
Bye.